you have indicated, you will lead me with questions, so I don't have a speech to deliver. Just to congratulate you on the last presentation from Mr. Louis Fourier. I really wish that I had been part of that one earlier myself, and probably not spoil it with all the issues, but just to leave everyone with a very positive mind that he has really, pitched his talk onto. I think what is important with what Mr. Fourier has raised is that every part of the world has got its own challenges, and we might sometimes be tempted to think that we're having the worst of all countries, but in fact, the reality is that we can if we put our minds together, we could actually fashion our country to be amongst the best in the world, certainly the best that we'd like it to be, because all the skills that we have and all the ideas that we have should be put together towards trying to get the best out of ourselves and out of our country. So I must say that this is a very, very encouraging message, particularly as it's coming at a time when we are all very nervous with this COVID-19 situation. At the same time, we have seen how before COVID, our economy was struggling, and how with COVID-19, it has also become quite more distressed. But I think the rest of the world is going through what we are going through. And so it's important just to look at what do we need to do to try and pick up our own economy and move forward. There will be always things that are going to challenge us, inadequate resources, our systems that could be struggling, problems of corruption, poor administration, and all of those issues. But as far as I would be concerned, a lot of those are issues that we can fix, we can deal with and fix. And then, of course, the whole idea is to be able to deal with the fundamental problems, the structural issues of inequality, poverty and unemployment in our country, was that it's a very, very important, historical legacy that we need to correct as we move on. So everything we do has to try and create a situation where South Africa offers the best, that offers the best for everybody in terms of job opportunities, in terms of education, in terms of health, and so we can actually see ourselves getting the best life expectancy and also enjoying life in a crime-free society. All of this needs all of us to work hard, cooperate, and also have the solidarity of understanding that what you might be having is something that someone else may not have. And in the process, there might be certain sacrifices we need to make across the spectrum to be able to help everyone to get a better, quality of life. And so I thought that the presentation was quite good. From where we sit, I think at this moment, our issues relate to the fact that on the past few weeks, we have seen the country emerging out of the surge of COVID-19. Our numbers are still going up at 682,215, with about 17,000 deaths that are recorded. But we have seen that the numbers of deaths, although increasing, has actually slowed down from what the numbers were. We also have moved from level 2 to level 1 with less of an explosion that than we had actually noticed when we moved from what was called level 4 to level 3 way back in June, where we started seeing all the numbers going up to the couple of hundreds of thousands and making us number 5 in the world. Of late, we've actually found a number of countries that have overtaken South Africa and relegated us to position 10 if you look at the coronavirus worldometer. So that for us has been progress in the way that is indicating that we were over the worst. Of course, we still have a challenge that we may still be facing a second surge. How likely is that? Is something that I think we can all speculate, because many of the countries that are overtaking South Africa are actually on their second surge, which means it's possible that the second surge can still come, but whether in South Africa it's going to be like that, it depends, of course, on how we deal with our containment measures. But with all of this, I just want to say to you as members of the profession that we do understand that you have played a very, very significant role in getting us to a point where we've got a recovery rate of 90%. And from that point of view, I want to say, as minister, as a colleague, as part of government, thank you. Thank you to you for all the work that you have done. And thank you to you for taking the real risk, because you know, the most difficult part is when you have to see the next patient and you don't know that that might be the patient that's going to infect you with COVID-19. But we have braved it all through. So all the health workers, we really want to salute them. And we want to say to you, you have done very well. We do have up to this point about 34,000 people, health workers who have been infected, and about 284 or so who have actually passed. But as we all know, that through all of that, we have actually had the majority of all the health workers persevering, patiently going out there to give the service to our people. And that's really why I thought it was important for me to come and interact with you and say, thank you. If anything else, just be aware that both as a person, a South African, as well as part of government and the Society of South Africa, we really thank you and salute you for all the good work that you have done. You have saved our country from what could have been a much more decimating, a pandemic. But of course, with all the work that we have done, we have actually seen it through the way that we have. So with that, I want to say thank you. We look forward to a conversation. And in such conversation, I don't believe that I've got all the answers. Some of my colleagues might also answer some of the questions, but some of them, you might be having the same questions that we're also asking ourselves. So it's a conversation. It's not a question that will have all the answers, but I think just to have the opportunity to share with you our ideas, it will be a very good evening from that point of view. Thank you very much, Dr. Kutsia. Over to you. Thank you.
Thank you so much, Minister, and thank you for acknowledging the hard work of the doctors and the healthcare personnel and in the background. It is so important, and I know that especially on specialist level, where those specialists who were treating the patients or still treating the patients in ICU, they are really burnt out, and I know it's not an easy time. Minister, let's start this conversation. I know you have already alluded to some of the questions that we're going to ask, but from SAMA's side and some of the members and non-members that ask us some questions, let's start with the COVID-19 currently, as where it is currently. And I know that you mentioned about the pandemic that or the second wave, that you're not sure. But if we look at the stats of the other first world countries, maybe it will come, maybe it won't, but we've got a good chance to have a flare-up again for a second wave. So when do you think we will be better prepared? That's the one question. The other question is on the vaccine trial, the vaccine trials, and if the vaccines are available, can you maybe also give us an indication of how you see, or your committees is seeing, who will get priority if it's available? And I think if you can maybe allude around the current corruption with the tenders and how it affects the healthcare. And if there's any, I know it's maybe unrealistic to ask you at this time what measurements are going to be put in place and how are we going to make sure that this doesn't happen. As Louis Fourie, made a very, very important observation regarding good old administration, which is not always so nice to do. But is there any plans there? So, Minister, it's over to you.
Well, thank you very much. I think that we would not be in a position to speculate about whether we will get the second wave or not. The chances are we will be like other countries. China had contained this infection, and sooner or later As soon as they started, other countries started opening up and people started traveling, they started picking it up. Literally, the countries in the West have actually all had it. The one that was very dramatic was the one in the US, where there was a whole wave and everyone was quite worried about it, and then started ebbing. And then suddenly, instead of going completely right down, it started plateauing and it shot up worse than the earlier wave. And so that's really made us to realize that there isn't a way we can say we have got a reason to believe that we will be spared from a second wave. The conduct of the pandemic is not the same in all the countries. One of the issues that we've been struggling with was what made us get the wave the way it actually did. We had predictions and modeling that showed us much higher numbers, mortality and positive and so on. And we couldn't quite explain why we didn't get to those numbers. But what we have been able to see is that some of the very limited studies have also indicated that what we have as positive cases recorded is less than what numbers could have been exposed on the ground. A study that was done in the Western Cape in the UCT, and part of also another part done in Eastern Cape, in Gauteng, showed that there was a much higher level of antibody response to a number of those communities. In the Western Cape, the figure was as high as 37 to 42%. They looked at some of the antenatal care, patients, people had come in really completely for different reasons other than COVID-19. And the same thing was done in the Gauteng, where they picked up the numbers ranging from about 22% for the children at under 5 and about 27% to 30% for those who are older. Of course, that's not an indication of the prevalence of the infection in the whole community. However, it does indicate that there are things we don't understand with the pandemic. But even if the numbers were as liberal as 40% as that study could have shown, which is in any case too high as far as we're concerned, there will still be a risk for the 60% who are not showing any antibodies. So the issue of the second wave, we cannot just rule out. We have then since invited WHO. They've given us a team which we call the Surge Response Team, who came in here we've deployed them in most of the provinces to work with the health system, health services at the district and sub-district level. Part of what we asked them to do is to help us to pick up the surveillance, the monitoring, so that we can we can pick up the change in numbers, any suggestion of a resurgence early on, so that we are in a position to say there's the need for us to focus and interact. I think that the fact that we have gone through COVID-19, quite clearly for me, we wouldn't have been able to be ready for COVID-19 at all. We could only get ready because we've gone through it, and you only discover a lot of things when you go through the pandemic itself. So I think we'll probably do much better than what we have done in the past because everyone really has a sense of what this COVID-19 is all about. I think the level of fear, anxiety will be less. The level of knowledge and understanding of what works will be much higher. The fact that there's a need to quickly shift resources into various areas, we will be able to roll out some of the programs, some of the field hospital beds that would actually close down much quicker when you get the indication. I also think that the coordination amongst all of us is going to be much better because most of the doctors here now have had to handle COVID-19 one way or another, and therefore it's no longer coming as something that's so much of a novelty that no one knows how to deal with it. So we have a plan now that's been tabled with us from WHO on how to deal with the second wave. We're going through that discussion at this point, and therefore I would say we are in a much better situation once we have gone through that plan, what I would suggest to the Director General is that we might need to come and share it so that we all are on the same wavelength when it comes to preparation for the future. The second question that you've raised is around the vaccine. All of us are aware that there have been over 200 or so vaccines that were being tried all over the world. Probably 20 or so that were getting closer to a point of further development. At this point, I think we've got 3 that are being on trial in South Africa, and all of these we've actually been in touch with some of the companies that are developing them, and we believe that we should work together with the global efforts towards the making vaccines more accessible, more affordable, even to the countries that may not be having as much resources. We've all been in various platforms where we've spoken against the question of resource nationalism, where people will only focus on putting all the resources to hoard the available vaccines to themselves. And so there's a whole global awareness of this particular issue. So the Gavi, which is the global initiative on vaccine access, has worked together with WHO, CEPI, and then they've created what is called the COVAX facility. That COVAX facility has probably got close to 180 or so countries that have affiliated to work together. And the advantage of this is that there are 2 ways of getting access to vaccine. On the one side, there's a bilateral arrangement where a country and a company can get an agreement where they'll work together for the development of that vaccine. The other one is a collaborative work, which is done through COVAX. This COVAX facility is the one that has enlisted the participation of more vaccine developers. It's got about 9 of these vaccines, which means that one of those vaccines should be more successful, and the chances of success is better in that than in a bilateral situation where you're dealing with one country, one vaccine. And so we believe it's a much better arrangement. It's a bit tricky because it's very expensive to put out financial contribution ahead of time, and we're going through those kinds of discussions as a country. But what it ultimately is looking at is that some of those developers are saying they think that the first vaccine, if the trials are concluded in October, they should be ready to go for application for registration licenses to the FDA by November, and then other countries will be following after that. That they are using what they call the messenger RNA technology, which makes it a bit different and quicker to escalate up to several millions by the end of the year, and cover over a billion next year. So the situation as it stands is that there's a whole global awareness now of the need for us to work together to produce to secure the vaccine, access to vaccines, and also to make sure that as many countries as possible have access. And the slogan is that no one will be safe unless all of us are safe, meaning that it doesn't matter if one country is going to make a vaccine available to itself. If the other countries are not, then of course the infection will still come back. And so that is the issue, particularly for us in the African continent who have resource constraints. There's a whole lot of philanthropist organizations that are also participating to assist those countries. So it looks pretty promising in the sense that when the first vaccines are proven to be successful, we hope to be there so that we are able to participate. And the target is that we should be looking at a minimum of about 20% of the population to create herd immunity. And so that's really the situation insofar as that part is concerned. The last point you raise is a question of corruption. Now, nothing has been as devastating and as embarrassing as in the midst of the COVID-19, you end up with a distraction that comes from incidences and reports of corruption. I think we as South Africans have to all take a stand that when it comes to corruption, we must all fight to uproot corruption. And in this case, the public disapproval of the corruption and the reports thereof is quite appropriate, and I think it's actually assisted for us to focus on saying, at least for the future of our country, this is one thing that we don't need, and that is corruption. We have worked very closely with the the Auditor General of South Africa to look at the risk factors in the whole country to see where things could go wrong. There's a process of auditing that is going on to find out when things haven't really been done properly. We also believe it's important to strengthen our supply chain processes and proper administration, so that even though there was an emergency procurement situation, that people can actually, should actually have followed the proper procurement procedures that are appropriate to the emergency crisis situation. The fact that at the beginning we had shortages and therefore we had huge prices going up, and also our systems of proper quality assurance were not as strong as should have been. All of this are now lessons that we're learning as we move on. We're actually working on a process now of strengthening the quality assurance inside our department, so that even if someone is procuring through a provincial tender, there must have been a proper program of quality assurance right across that makes it unnecessary that out of desperation, provinces could procure any that is available. So, but I think from now on is another lesson that we have learned. We have to work together and cooperate with the prosecutors, the DPP, the NPA, the Special Investigation Units, police, and all of them to be able to ensure that those cases are uncovered and that there's consequence management associated with corruption, so that as we move into the future, corruption is dealt with. Even if we get to the future, as long as we make sure that there are very strong measures, the check for checks and balances, and quick consequence management and investigation on such cases, will always be able to prevail over corruption, because corruption will always arise every now and again when the administrative weaknesses are identified. So I believe that we need to strengthen that part as we go on. Thank you very much. Let me hold it at that for now. Thank you.
Thank you, Minister. Can I ask you your view? This was one of the questions raised by not only SAPPF, but also SAMA and some of the other organizations out there, including MPS, that during this COVID-19 period, that we asked for a blanket exemption from prosecution of malpractice claims that might be brought against the healthcare workers outside the scope of practice as members of a COVID team, because this is not related to the COVID. And is there any movement on that, Minister, or do we need to set up a small task team to look at this?
I'm going to ask that some of my colleagues can respond to this. Although I don't think that we have come to the conclusion on the matter, I think we will need to have an ongoing discussion on it, because it's a matter that was raised quite, I must say, when it was raised, I hadn't been quite aware about how seriously the matter was affecting the profession. And so maybe we could ask Dr. Nicholas Crisp to make a comment. But I think we need to then talk about the future arrangement in terms of how we're going to handle the matter going forward. I'm not sure if he's around, or maybe if not, Dr. Anpan-Pillay. If neither of them are there, then we'll see. But I thought that they would be able to just give us a bit of insight. Dr. Crisp first, if we can find him. Okay, it doesn't look like he is in. We will probably come back to that issue a bit later. But let me then say that that matter was raised, and we had actually said that the team that was working. Are you
I'm
in?
here now. Yes, I was here, but I couldn't speaks. Thank you,
We
Minister.
couldn't deal with technology, sorry.
They
Doctor has a bad name.
Nicholas, you can proceed.
Just give them a moment.
Thank you for letting me in again. Okay, am I audible? Yes. Okay, thanks very much. Thank you, Minister. So, yes, the matter was raised with us, and we did take some steps during the early part of the epidemic to raise it with HPCSA, as you will recall. And for those who are members with the MPS, it was raised with the Medical Protection Society. And there were some steps taken by them as well for their members. Then we discussed the matter with some legal firms who had different opinions and consulted with various parties, including SAMA, and have put together a proposal on how to approach this. But as the Honourable Minister says, we didn't, things moved so fast, we didn't get to a conclusion. So we have done the groundwork, and I'm sure that's something that we must take up in the department. Thank you.
Thank you, Chris. Dr. Nhlapo once again here. The next question, Minister, comes from one of our colleagues, and it relates to the criminalization of doctors. There is a grave concern about the arrest of doctors before the completion of a formal inquest or any interrogation of the facts that would have taken place in a given clinical situation. In March this year, the representative groups sent a letter to the Minister, the HPCSA, Director of Public Prosecutions, and the Minister of Justice. In those letters, we outlined some of the concerns that we had with this particular activity. So we'd like to know if Minister can shed some light with regard as to what is being done to ensure, in the first instance, that due process is followed and that formal inquiries are allowed to run their course to completion before criminal sanction is applied. Related to that, as the second part of the question, is that we would like to find out if the HPCSA can, in a timeous manner, be able to fulfill its obligation of protecting the public and at the same time guiding the profession. I'll take this opportunity maybe just to add a matter related to the safety in the work environment. Our colleagues, both doctors and other healthcare workers, are requesting a safe working environment. And this would include the infrastructure. So a point is being made that some of the health facilities are literally falling apart. And in some cases, we've got poor maintenance that is being carried out at the facility level. In relation to security, we have issues with safety in the workplace, as being reported in some of the media coverage in the last few days. So we'd like to find out from the Minister if, or just to understand what is being done to ensure safety in public facilities in particular, and maybe related to that, while we're talking about an optimal working environment, if the Minister could shed some light on the perennial and ongoing, stock out of essential medicine that often happens in a number of healthcare facilities. Thank you.
Thank you very much. Because we've got a number of the colleagues here, if they wish to come in, I'd like them to be able to just indicate. On the question of the stock out of drugs, I'm going to ask that Dr. Anban Pillay could also just comment on that issue. I'll comment on the two issues, the question of safety at work and the question of the arrest of doctors. The issue of the safety at work is a matter of very serious concern, and I think all of us are aware of a number of cases where people have been hurt at work. Now, the real area where we've really had a problem where those who have succumbed from the criminal activity, which is linked to the poor conditions, poor security situation around the hospitals. And this we have seen in a number of areas. So when that arose, there was a very terrible incident in Pelonomi, and then we had another one in Limpopo, in Mangoeng Hospital, where there were direct attacks on some of the people there, and particularly one was a lady who had an attempted rape, and she had to fight quite fiercely on that. And the other one was a lady who was discovered after a few days having lost her life. And of course, there have been a number of instances of patients who have attacked the staff, and then also instances of patients who have been followed by people from outside, and then they were actually killed inside the hospital. These have been very, very distressing situations for all of us. And we had meetings where we had to then ask for a strategy to be worked on with the police to try and look at ways of how we can tighten the security. And of course, we've charged our hospital management to deal with some of the basic issues of security, the issues of sorting out the alarms, the controlling of the entrances, and the blocking the thoroughfares through the hospitals, and those kinds of issues, but also tightening up on the security at the gates to make sure that people who come in can be accounted for, and that if there is anyone who's suspicious, can be dealt with in time. The discussion has also gone to looking at what can be done together with the police. Some of the strategies that have been discussed have related now to looking at whether, in fact, police could actually work together with the department, with the hospital, and post some reservist police to reinforce. And so those issues have still been under discussion. But we have actually said that there must be a very strong review of the security in various hospitals, so that some of the simple things like the cameras should be working, and the surveillance over the those cameras to look at the movement of people, suspicious movement, and so on. So in some of the areas we've seen that is being done quite adequately. There's still a lot of areas where we think that more needs to be done at that level. We can just say that we do accept the concern of our staff when it comes to that matter, and that we will continue to work with them on that. When it comes to real degraded infrastructure, some of the areas are subject of current reviews and management and refurbishment program. But of course, some of the hospitals are part of the longer term infrastructure upgrade, which has been quite delayed. And in this case, there are instances where hospitals that should have been refurbished over a long time have really not been successfully refurbished. And that's an issue that we continue to work on. In fact, my wish in the whole department was whether, in fact, it's not possible to look at all the hospitals and do one combined program that will actually help refurbish and create the new hospitals that are needed, replacement hospitals, and so on. That's an issue that we are having an ongoing debate with the different departments in government, because it's got a lot of other issues that are associated, and it's more hopeful now that there's been a discussion that's relating to how we should reactivate the public-private arrangements, and also looking at build, operate, transfer, those kinds of instances where we have to find alternative ways and not be stuck by the fact that there's inadequate resources. So this is an issue that we will continue to work on, and at any one time there's a matter raised, we'll try and give attention to those particular areas, but we've sent a general a directive for the issue of security to be prioritized. The issue of the doctors being arrested, it must be really a matter of shock with all of us that we've seen the way that the one case was handled, the case that related to Professor Bill and Dr. Munsi, and this was brought to our attention much earlier when there were actually prosecuted, arrested, and then charged and prosecuted. And it becomes very tricky because then, how does one get involved once there's an involvement of the police, the prosecution, and so on? It's almost like you are now trying to defeat the ends of justice if you want to step in just like that at that level. It made it very difficult to deal with it like that. However, what we then did was to convene a meeting with the Directorate of Public Prosecution and the Minister of Justice to discuss this issue specifically, together with the President of the Health Professions Council of South Africa. And we raised this issue that there is an unusual and anomalous approach that we have noticed, which we really don't believe must be encouraged, because it can create a kind of precedent that would make all the doctors, particularly all the health professionals, particularly doctors, to feel that as they practice their profession, it's becoming more risky and even less professional when they are criminalized. And so we went through this discussion based on the Inquest Act of 1959, wherein for any death that is related to pre, post, and peri-operative procedures, there is an inquest that is supposed to be followed, and that out of that inquest, then of course there could be a recommendation for prosecution, there could be a recommendation for lawsuits, whatever, but nevertheless there is a standard approach which we all know and accept is a way that we need to be following up on these issues. So we have then had that discussion. We agreed that more of these details of what happened are going to be that they will be shared with the Directorate of Public Prosecution, and in that process, we will then come back to look at maybe we need a kind of memorandum of understanding, so that where there might be loopholes that could have been utilized, that we need to close those with a clear understanding as to how in future we'll deal with this situation. The matter is not over, therefore, yet. What we're expecting is that as soon as some of the basic information has been shared between the HPCSA and the Directorate of Public Prosecutions, they'll go into the matter and look at what has happened in this case and then deal with it. There's two separate matters which we must keep in distinction. One is a case in court, which we don't have any jurisdiction over. The other one is the approach to instances where there would have been any patients that's lost in the process of treatment, so that it must be clear that this is a procedure that we follow. So we have therefore urged that we must continue with the procedure that we all know, and that we must get explanation as to under what circumstances does this change and deviate. So I would say once that has been properly discussed, we will come back and then address the profession to say what are the issues that we have found. But we would agree with you, and of course, those who represented the Directorate of Public Prosecutions did concede that as far as they knew, that's the approach that should have been done. However, there seems to be certain circumstances under which you cannot necessarily stop the prosecution, but we thought that maybe once we've gone into the details, we'll analyze whether in fact did this case fit that situation or not. But because the matter is in court, it will not be correct for us to continue speculating about the case as such. However, what is important for us is to talk about the procedure, so that we make sure that between us, the health profession, as well as the Department of Justice and the Directorate of Public Prosecutions, we are on the same wavelength, and we know how to deal with the situation when it arises in the future. Thank you very much. Can I ask if Dr. Anne van Pile can deal with the issue of the drug stockouts?
Thank you, Minister. Good evening, Minister, Deputy Minister, Dr. Coetzee, and EXCO members of SAMA and colleagues. Thank you for the question. So I think on the issue of medicine stockouts, historically we've always had shortages of medicines globally. And I think what COVID-19 has done is basically exaggerated that problem. Our biggest problem at this stage is largely linked to drugs related to oncology. Secondly, drugs in the psychiatric sector, as well as some of the lower cost drugs that are in short supply. The problem in the current context relating to COVID is related largely to the supply routes. As you know, a number of drugs are produced completely overseas and shipped into South Africa. And with the decline in the shipping routes as well as the air cargo routings, the opportunity to get stock into South Africa has been reduced. I also understand that the cost of transport has now increased twofold or so, and so some manufacturers are no longer keen to supply their product, given that they have pricing commitments here, given the tender system, etc. So those have all, to some or other extent, contributed to the problem. And then we have those drugs that I think are a continuous problem, whether there's COVID or not. And those are largely the lower cost medicines. For example, your oral contraceptives have always been products where the cost of production is very low. The challenges of producing the product, given the regulatory requirements, have resulted in very few manufacturers being interested. And this has largely become an imported product when it was previously available locally. So I think all of those have made a significant contribution to our current medicine shortages. And what we have been doing at the beginning of COVID, in fact, before we had our first case even, we were meeting with the pharmaceutical industry, and we had identified this as a huge risk and tried to put in place measures that would reduce the risk of greater shortages. The South African Health Products Regulatory Authority, SAPRA, has been very helpful in this area, where they've fast-tracked the emergency use of a lot of medicines, particularly where there were API shortages and the like. But I think it's a global problem that we're all battling to try and solve. I think until there's restoration of the global shipping as well as air cargo routes, we anticipate that these problems are going to dog us from time to time. Thank you, Minister.
Over to you, Dr. Ekoti.
Thank you. If I can, again, Minister, it depends whether you or Dr. Pillay or whoever would like to answer, but also got the questions regarding that currently there's a problem with Roche and their contract with SAPRA regarding injectables. But part of the problem is that they do supply a lot of injectables for pain relief, and we are now running out of that because of difficulty in the contract. That should not be an electronic contract. It should be a hard copy contract. But the problem is there's a problem there related then into, and I don't know whether the doctors are yet aware that we are going to run out of stuff like diazepam injectables, which can be have disastrous consequences in epileptic or seizure patients. And so that I think if we have escalated this question this week to SAPRA to ask to please, can they speed up the process? And pain relief is a huge problem in South Africa, especially post-operative. So yeah, we are going to run out. So I'm not sure whether you are aware of the problem that's between, that's relating to contracts. That's not in the, the international community doesn't want a contract in electronically, they want it in a hard copy. So that is really, if you can maybe look into that, that's one thing. Then on the question or the answer, about the criminalization and what has been done. Minister, you have gave us quite a big good feedback on what you are doing in the background regarding this. But from SAMA's side, and I think a lot of the other non-SAMA members here would also agree that this is a problem related to the profession, and we would also then would like you to look at a small task team also from the professional side, because in the end of the day, it is us that is sitting with that, so that we can advise and help and come up with a good way forward. And this is one of the problems that we identify, that with all due respect, the Department of Health and all the other departments and health professionals council that's involved, and everyone tried to help, but then you actually forget that we are still there. It is like the patient sitting in front of you and you speak over the patient to the mother that bring the child in. So if we can just come back and remember that we are actually the patient and we need to be part of the solution. Then another question that was raised is regarding, I'm not sure, Minister, how far you are, but remember there was this chronic medication that was gazetted, and which SAMA and the Unity Forum of Family Practitioners then raised objections, and it went back to SAPRA, and they, as far as we know, they approved or were in line with our objections, and that document is still not been signed off. Can you maybe give us feedback on that before we go further? I think this is enough for now. If you can give us feedback on that, please.
Thank you. I'm going to ask that Dr. Anpan Pillay can comment on this document that you're referring to, the last one, which was approved and but not signed. And so if you could recall what's happening on that. The other one is the Roche contract with injectables. Khadija Jamaluddin, I think she's in here, if she could also comment on that one. Let me just say, whilst preparing that, yes, indeed, it's not so much that we have a doctor talking past the mother and to the baby on her back. There's a bit of a tricky situation that we're managing. The first problem is that we have a case in court. Now, imagine if we went into this issue and somebody misrepresents it and thinks that there's a political interference on a court process. So because of those sensitivities, we then felt that the starting point, let's deal with it as the regulators as well as the policy enforcement sections, which is why we thought we must get the Directorate of Public Prosecutions and the Minister, and of course the Department of Health and the Minister of Health on this matter, together with the HPCSA. We then agreed that the Director General, together with the HPCSA and the Directorate of Public Prosecution, will go through the framework and discuss the issues and then identify what the loopholes would be. Now, if we were to bring in SAMA immediately on that issue, it would have been a bit tricky to deal with an issue where we, from the side of government, are not in a position to explain what has happened, and then we bring in the direct complainant into the matter. Now, the idea was that once these three teams are in and they come back with an answer, then we can then engage with the medical association, because then we have clear answers onto the issues that have been raised in the letters before. But if we ourselves did not even understand why there were differences in approach, it was not going to be helpful. So rest assured that that time is going to come where we will then have the medical association involved in the discussion. There may well be a need for us to start dealing with the question of a team working together, particularly as we start identifying there might be areas for memorandum of understanding, because it's going to start involving various players, not just the one department that is the police or the Department of Justice or Department of Health or even HPCSA. So at that point, I think it will be important. So when we come back with that next feedback, then let's raise this issue of a task team, and then we're going to go through it, because I don't believe when we come back, we'll have closed the issue. It will be, we'll be able to explain why there are differences in the approach and why, what needs to be done to deal with them in the future. And you'll have your suggestions on that same issue. So I think there's still time for it. Just that because we were all dealing with the COVID situation, some of the issues have not moved as fast as they should. But I hope that within the next week, 2 weeks or so, we should be able to get back to get this discussion. If it was not for purposes of this discussion tonight, we would have actually still have requested a meeting for SAMA to get a discussion on this matter, so that we can take it from there. So I think we're still on course on that. We'll accept the suggestion of a team, but that will be at the point when we come back with the feedback. Then could I request that Khatija can deal with the issue of the contract with injectables?
Okay, thank you, Minister. Good evening, everybody. So with regard to the injectables, in the public sector, we use the generic version of diazepam. So we don't have Roche as a contracted supplier for diazepam injection. From what Dr. Coetzee was talking about, I understood it to be an issue with regard to the electronic submission of a dossier for, or an amendment, a request for amendment to SAPRA. And if Dr. Coetzee can give me the details of that, I can perhaps assist and liaise with SAPRA to find out what the specific issue is and assist with resolving that issue. In the public sector, we, as I said, we have a generic manufacturer as our contracted supplier, and we are not having a stock out at the moment of that particular product.
Thank you, Minister, and thank you, Khadija. I just need to also make you aware that we can't find diazepam, the generic, in the private sector. It's out of stock. So maybe we need to buy from the public sector because there is no stock. Minister, yes, just to come back, and Khadija, yes, I will offline communicate with you. What we also would like to, that it's not only to look at the current case, but also going forward to see how we can negotiate and what measurements can be put in place so that something like that never ever happen again, that there is another way that we can do it on that line. So, Minister, then I have two interesting questions. I know the answer to one of them, but that was sent to us.
You still have the question about the approved documents that Dr. Anban was going to respond to.
Sorry, thank you. That's why we are a team, Minister. Thank you, Anban.
You're welcome.
Thank you. Thank you, Minister Dr. Coetzee. Yes, just to refresh our memories, this was the matter relating to the extension of repeat prescriptions, Minister. Originally or usually, a prescription has a validity of 6 months, and during COVID, there was a proposal from SAPRA at the time that there should be an extension of the prescription validity up to 12 months. And that was an issue that was caused a lot of concern in the way that it was structured. So there was a meeting with SAMA as well as the Pharmacy Council and the Association of Pharmacists as well. And we managed to get agreement around how the proposal needs to be structured. And after that agreement, SAPRA had said they put together a revised gazette, which they were going to submit to you. I was not aware that that had not been finalized, but I will take it on myself to follow up with SAPRA and check where is that Gazette currently, because I think that's what Dr. Coetzee is looking for. Although we agreed about it, it obviously has to be gazetted as well. Thank you, Minister.
Thank you. It is indeed that document that we are referring to. Minister, can I ask the next question? I can't, so, okay. As I said, I think I know the answer already, but this has been asked. So the question that was raised here is, with the recent changes to the Ministerial Advisory Committee for COVID-19, it appears that the involvement of a handful of scientists that disagreed publicly with the Department of Health response have been terminated. And then the question is, should South African scientists and specialists be concerned about being excluded from contributing to health service planning and strategies if they disagree with Department of Health mandate? I think I'll just park that question there for you, Minister.
Thank you very much. Well, it's a wrong impression to think that anyone who we disagree with cannot serve. Let me put it up front. If there is any disagreement between me and any other member, I will disagree with them in public. We will debate it. So there is no problem with that. What happened here is that we went into the creation of the Ministerial Advisory Committee under various conditions. We're under pressure. We then created a committee that, those that we could think about. It was one unusual committee that it had almost 50 people who were there, and all of them were the topmost professors in the country, topmost experts and so on. I have huge regard and respect for all of them. In fact, we had a lot of value with them being there. But the problem as we're moving past the surge, we needed to relook at how to respond. Firstly, the committee needed to be structured with the inclusion of various sectors that had been overlooked at the beginning of the surge. We had a lot of debate at the National Coronavirus Council about the fact that we had left out some of the specialties, particularly the humanities and socio-behavioral scientists, and that area was becoming more and more important when we're dealing with the issues of behavioral change. So it was inevitable that we're going to have to restructure the Ministerial Advisory Committee. But in addition, we had also found there were two other strands that needed to be accommodated in this issue. One was a multi-sectoral team of advisors that would be structured along the lessons we got from HIV and AIDS, where government was focusing on policy issues, but the stakeholders assisted us in mobilizing for social behavioral change, dealing with stigmas, and pushing the message on the ground. So we created this committee now on the side. It became clear as well that not one department is needed here. In the case of the multi-sectoral committee, we needed to work with COCTA, we needed to work with the public, with the Department of Social Development, which we did. Then a whole new area of urgent attention arose on the vaccine development. We had to now split the group and actually create another committee that's going to focus on the issue of vaccine. So that group now meant that the day-to-day things that we had to deal with, the problems of negotiating with CEPI, with the COVAX facility and the vaccine developers and so on, needed its own attention. Now, you've now, out of that first original Ministerial Advisory Committee, you've ended up with 3 committees which are all advising us on the issue of COVID-19. So when we structured the way the committee is now operating, we then had to take all of these issues into account. Now, the people who are in the committee, who are still part of the committee, I can't say that all of them have never really disagreed with government. I've actually seen a few of them who have been very vocal in public, who have raised various issues. Some of the people I actually engage even offline and talk to and so on. And so there's always going to be debate and discussions at that kind of level. I think that people who have got views which are different to government must always know that their views remain important. We must hear them and they must be raised in the whatever level. Depends on the nature of the issue, because if the issues are members of the advisory committees differing in that committee, then the idea is that it's the debate that's going to give us a solution. And once they've finished their disagreement, they'll come to a conclusion. So differences inside the committee are not a problem. They have to be managed with the understanding that we come from different experiences, and that at the end of the day, we need to advise on specific issues. So that's not a problem. The second issue is that there may well be issues where people will differ with government. Now, every day people are criticizing government, they're arguing against some certain decisions that government has taken. We as government have to take into account some of the views that some of the Ministerial Advisory Committee advisories will share with us. Most of them we've implemented, even though there's been criticism on us. Actually, we've implemented almost everything that was put on the advisories. Where there were differences, we have actually explained why, considering various other factors, was important to be able to deal with the challenges that we had to face. And so, for example, just to give one example, there was a whole discussion around the de-isolation from 14 days to 8 days. And in the discussion that we had, we ended up having to consult WHO and a few other players. And then we went back to the members of the committee and said, look, we don't understand where you come from, but we think that the discussion that we've had is going to create a bit of a challenge if we can't explain why we have a WHO view, your view, someone else is still at 14 days and all of that. So we need to align all of that. So aligning that is the work that we have to do. So back to the question, anyone who has a view in South Africa must continue to express that view. Where we have criticism, we will explain our position. Where we've got a debate, we'll enter into the debate if we think it's necessary. It's a free country, so we must not feel in any way constrained. So anyone who's got any view, you will continue to serve where you're serving. And we believe also that you don't have to serve only in the committee. You can serve as part of the broader body of experts that has got ideas. Some of the people will get their views even if they're not part of the committees. So at the end of the day, the Ministerial Advisory Committee had to be configured based on the points that I've raised, and because we've ultimately got 3 committees out of 1 committee, and therefore we needed to try and streamline them like that. And by the way, there are lots of advisory committees that we actually have, on cancer, on microbial, what you call antimicrobe resistance, and a whole lot of other issues, maternal and child health committees, etc., etc. So quite a number of them. So it's not just that, and we change the people in the committees as well. You create, you bring in new people, you get in additional people, and when that happens, it happens offline, and so it's got nothing to do with what people's views, what views people hold. So I would like you to just understand that and relax that there will always be space for all of us to participate. Thank you.
Thank you, Minister. One last question before we go over to our request and to look at Independent Medical and Dental Council. One question that this has been asked before, and I think it is an important question. That the background is that in your rural health facilities, the referral pathway for patients in need of mechanical ventilation is almost impossible. Yet those facilities were able to keep the COVID-19 patients alive with simple high-flow oxygen, which is significantly less resource intensive than the ventilators. And the question now is, Why aren't resources being directed to upscale the provision of oxygen to the rural health facilities instead of ventilators that require more specialized nursing, monitoring, and infrastructure? Thanks.
Very, very good question, because we have actually learned a lot out of COVID-19 situation. When the whole COVID outbreak happened, our focus was that we needed to make available lots of ventilators, and there was a whole, modeling around it, how many ventilators we need, and there was a lot of panic about it as well. And as the situation moved on and we started experiencing COVID and learning from other countries, it became very clear that early use of oxygen, was most important, particularly high flow nasal oxygen, that it was very, very important. And that in a number of instances, it was better to treat the patient with supportive oxygen therapy before getting them onto a ventilator, that the mortality from ventilators was much higher than situation when people would have been able to avoid the use of ventilators. Then in the process, it became also clear to us that we needed to make oxygen available in small hospitals. So a whole new program started when we now had to go and put oxygen tanks and concentrated oxygen tanks in various hospitals. And this was the way we had to go. In fact, it helped us because we started putting additional oxygen points in hospitals that didn't have it before, that didn't have as much of the support. I think the experience that we got from the clinicians has helped us to shift the approach. I went into some of the hospitals and looked at how, with the existing oxygen cylinders, the oxygen tanks, how the use of oxygen had actually rapidly increased. It increased to such an extent that those condensers outside the tanks, the oxygen tanks, started having a whole cakes of ice building around them, to the point that they had to use water hoses to wash them down because of the rapid speed which oxygen had to pass through to actually get to the high utilization wards. Now, we therefore felt that it was important to set this up in a number of areas, and we actually had to talk to the main oxygen manufacturers and created a whole special program. And this has actually improved a number of hospitals. What I think is important is to say, going forward, all the hospitals, no matter how small, and health centers should be able to have access to oxygen earlier, because you will actually notice that many of the people will be saved by that even before they need to go to ventilators. And that's a lesson that we have learned. And I think it's a very, very important lesson, because when we started, the preoccupation was around the use of ventilators. But with time, it became clear that the real issue is access to oxygen. And that was actually more useful in preventing people getting to deteriorate. And so that's a good lesson that we have learned. And going forward, we're going to have to use that, because it actually helped us in the COVID situation, but it actually exposed a situation where there wasn't adequate availability of oxygen in a number of areas, and we have to rebuild from that point of view. So I think it's a good lesson that we have learned from COVID-19. Thank you.
Thank you, Minister. I'd like to come in with a set of 4 questions, and that probably will slowly lead us to the end of the session. The first question relates to a previous engagement that we've had with the Department of Health, where a list of over 500 young doctors, we had double-checked and made sure that these were registered with the Health Professions Council, remained jobless. And I would like to get a feedback on that matter. The second one is related to the healthcare workers Provinces like the KZN has been living with understaffing of healthcare workers like nurses for many years. And the question relates then to the budgetary constraints, which have always been cited as the reason for the shortages. The colleague would like to know that if you've managed to utilize the pandemic to bargain with Treasury so that the healthcare sector gets its fair share of the budget. And related to that, then we would like to get an update on the NHI. And there are some other questions that are probably relating to that, but an update on the NHI and the progress that has been made towards that. The third question is quite topical at this point in time, and it relates to the telemedicine. A big problem facing GPs at the moment is the explosion of virtual consults directed by nurses to virtual doctors. And this is particularly so at two big commercial pharmacies, Clicks and Discam. This opens up a number of problems, among which you have an issue of supersession, touting, and canvassing. The colleague would like to know if this process of allowing the virtual consults has been thoroughly thought through by both the department as well as the Department of Health. The last question then, Minister, will relate to the NHI contracting. The contracting of GPs, the colleague would like to know if it's going to be happening as a selective contract at the district level to complement the services that the district wants, or will the GPs be able to join the NHI network as equals with the national contract? The view is that the bill as it currently stands seems to be suggesting that it should be the former. And if the minister could please comment on that. Thank you so much.
Thank you very much. Let me ask that some of the other colleagues could come in. Dr. Anban Pillay, Dr. Aquina, I thought Dr. Gail Andrews was here, but maybe you've shared some of this with Dr. Andrews. So Dr. Tulara, you might want to comment. And then Dr. Pillay Anban, we can handle the other issues after that. And then Dr. Crisp on the NHI and contracting of GPs. Yes, let's pick it up from there, and then I'll come in afterwards. Is Dr. Tulara available? Okay, she's not available. Can we get Dr. Crisp to come in, and then we'll have Dr. Pillay after that? You can deal with this. I think Dr. Andrew spoke to you as well about this one on the employment of doctors.
Minister, thank you very much. Thank you. I can respond partly on the GPs to say that during COVID that we had a number of engagements with SAMA and others and gathered lists which were integrated together with various provincial lists that people had generated. And the Human Resources Management Directorate in the Department of Health was trying very hard to join the dots around a number of challenges. Some of the people on those lists are not registered with HPCSA, and there was an engagement with HPCSA to see how many of those could be dealt with. Not all of them was it possible, and but for a number of them it was possible. Then as far as employment was concerned, we had a number of interventions where we tried to simplify the explanation of different ways of engaging GPs during COVID. And that had quite a lot of success in the Western Cape, where they did employ people to work on in various COVID facilities. And as far as I know, there are still many of them employed. In other provinces, it's been less successful, and we have had complaints about some of the provinces. So I don't have the exact numbers here, but perhaps Dr. Tulare might know more about that than I do. If I can speak about the NHI GP contracting, I think we've still got some way to go with that. There has been a pilot, as most people are aware, And during the pilot, there were contracts that were issued, and some GPs were contracted in the pilot districts, and there was a report written about various success factors. We've had some discussions with SAMA and others in the recent past about that, but the way in which the bill is worded, the intention is to create multidisciplinary teams in the contracting units for primary health care. And the question is, how do we best engage the general practitioners in their private practices? Not necessarily as contracted employees of the state working in clinics or in outpatient departments, but where patients can see the general practitioners in their practices and how we might structure those multidisciplinary practices. So I don't think that there's only one solution to that problem. The solutions are likely to be different from rural to urban areas and even within urban areas. So I think you can look forward to a lot more engagement before we get that far down the NHI road. Perhaps I should leave it there. Thank you, Minister.
Could we ask Dr. Anban Pillay if he wants to comment on any of this, particularly the issue on the virtual contract, the virtual consultation? I'll also comment on that a little bit, but let's see if there's any other comment, then I'll come back into that. Dr. Pillay, Anban Pillay.
Thank you, Minister. I see Dr. Tulare has also joined us now. On the virtual consultation, there is no formal approval that comes from the department on it. My understanding is that HPCSA had been engaged on the matter, and this is, and I think the Nursing Council as well, from what I understand, and that's how the approval was granted. My understanding is it was also granted on a pilot basis, and they had to demonstrate proof of concept, etc. So I'm not sure if that has been completed and whether there's now an approval for a nationwide rollout on it. I do know during COVID there was an argument that it may be the most appropriate approach, but beyond that I'm not sure. Maybe Dr. Tulare would be able to assist the Minister.
Okay, if there's any comment from Dr. Tulare, that's fine. Otherwise, I'll take the next. Dr. Tulare, you want to come in?
Thank you, Minister. My apologies. Technology was stumping me. Firstly, maybe let me just add to what Dr. Crisp has said about the employment of doctors, that in discussions with Dr. Gail Andrews, what she indicates is that during the era of COVID, we employed around 13,000 healthcare workers, and these included nurses and medical doctors. But at this stage, we are still working on breaking down, especially because most of the doctors were employed by provinces, and we are just cleaning our database, and we can come back to SAMA to indicate where we are with the 500 names that they had provided. So it's something that we can come back to, Minister. And then I just wanted to also add on to what Dr. Nicholas Crisp had said about the employment of GPs or contracting of GPs, that in addition to the issue of multidisciplinary teams, what is also of critical importance is to ensure that we comply with standards that have been set out. And this would work through what the Office of Health Standards has proposed around the standards that must be maintained in GP practices, as well as also to make sure that the processes of performance requirements, whether it's in terms of submitting information, using the appropriate IT platforms, and also in terms of agreeing on a pricing structure that is going to be used, have to be clarified before we go full speed into the contracts, because from our experiences previously, especially if you look at the issue of pilots, we still have to do a lot of work on GP contracts to make sure that it's something that we can all agree on. On virtual consultations, Dr. Pillay has responded and to indicate that when HPCSA initially agreed and approved the policy of virtual consultations, we had said that this is a question of emergency, but we understand that in terms of how technology is moving, the issue of telemedicine or virtual consultations will take place. But we have to look at a lot of ethical issues and making sure that virtual consultations do not become the norm, especially if you have not seen the patient previously. That relationship has to first be established before we revert to a situation of virtual consultations. And there are lots of models that have been studied even in other countries where there are pros and cons of allowing this practice without establishing a formal, proper doctor-patient relationship. That's all that I want to add, Minister. Thank you, and thank you, Dr. Kutsie.
Well, if I can just come in, Dr. Kutsie, let me suggest that on the issue of the doctors that were supposed to have been employed, because we were aware that there were a number of issues here. The doctors were employed. We're also aware that some of the doctors were not registered. But what the question now is about reconciliation of the numbers, where I wouldn't be able to answer that. I think a team from SAMA, together with Dr. Andrews, can look into that issue and then come up with the answers to say what actually happened. So we could suggest that together with the DG, we can follow that up and then we can have a clear answers to what happened. From where I sit, we had said that all the doctors that we can find, we must employ. Now, out of 13,000 staff, 500 doctors are not a big number. We had actually opened up all the provinces for that. And so what ultimately happened is something that we must then sit down and look. There are obviously other dynamics that come into it. Certain people preferring to be employed in certain parts of the country where there are no posts and all of that. So those issues, we need to be very factual. I think when we deal with this issue, we need to say, let's go to the nub of the problem. When we talk about doctors who are South Africans who have qualified in other countries that cannot get registration, we can't take those because then they have to first go through the HPCH registration. So this team can tease all of those out and then we can have a joint report on that. The second issue relates to the telemedicine issue. I think as Dr. Anban was indicating, it started as more a kind of trial situation. It's a HPCSA that said it can be done. From what I recall, some of the doctors even in summer were actually saying, no, look, it might be risky. Why don't I just, because I know the patient, and the feeling was those patients that have been consulted before can be looked at in that way and so on. Now, if somebody decides to stretch it and then there's suspicion of touting and there's canvassing, the chemists are now taking advantage on and so on, maybe we need another group that looks into that, give us a proper issue. Do you want us to investigate this? What exactly is the complaint? And therefore we can deal with it from that point of view. From where I sit, I think that we need to talk about going forward, what level of telemedicine are we going to use? There's a lot of value for telemedicine, but there are areas where we might feel that is not appropriate. So we need a conversation on that. And so we could have a discussion. If I recall, somebody did say that there was a team in summer that's looking into this matter. And so if that's the case, let's discuss it from that angle. Then the question of the contracting of GPs has been dealt with. Then the question was, have we been able to bargain with Treasury for more resources? Without a doubt. All the new, the additional cost came from funds that Treasury voted specifically to support the Department of Health. People may not be aware how the Minister and the Director General of Treasury have actually sat down and worked throughout all our projections and estimations to give us all the support that we needed. Where they couldn't do so, it's because I think there weren't enough resources to go beyond what they did. But the Minister of Finance even had a kind of expression that basically said, if it's COVID and if it's health department, we'll find the money. That's been the approach. So I think it has been very, very helpful. The only problem in this whole matter is that the fiscus is going through a lot of strains. Now, over the years, we believe that health should have been given a lot more resources, but knowing the competing priorities in the country, it has made it difficult to always, get as much as we believe the health department needs to be given. So even as we move into the future, we will always say that we need health to be given more resources. Health is underfunded, but it does not take away the fact that when we had a crisis, the Department of Treasury of Finance actually arose to the occasion. From the president to all the ministers, we did have a support to say, as much as possible, give to the Department of Health. That's why we just said, go and employ. Go and open up those beds that you need. Don't argue about money. And that's been, the president was public about it. And so that has actually been the situation. Can I take advantage whilst I'm here, because I've ultimately been able to decipher your system. So I've picked up a few of the questions here, and I'll just comment on them very briefly. One of the questions that has been raised relates to why did we pay money for Cuban doctors and then the Nazareth doctors were supposed to be volunteers? I think the person who asked the question did probably miss the flow of the discussion. Department did not ask for volunteers in Nazareth. It was the doctors who, out of their own initiative, called for volunteers. Then we were in contact with them, we discussed with them, and I recall because Dr. Tom Boyle, who had actually been in the forefront of this, we had a lot of discussions about it, and I ultimately said to them, if you find a doctor that is available and is properly registered, send them over to the Gauteng HR department for a proper employment, so that there's no one who can be actually put in there as a volunteer. The only people that we expected could have become volunteers would have been doctors, let's say in private practice, who thought they needed to have exposure on the management or to come and support in the treatment of patients and management of patients inside the hospital, that could have come across, and they might have wanted to do that on a voluntary basis. But if anyone was contracted, they should have been paid. So if the question is why somebody was not paid, please let me know, get me the details so I know. I'll check why that particular person you are referring to was actually not paid, because there shouldn't have been anyone who could have been not paid. But the call for volunteers was the doctor's call. We stepped up and actually got to work with them. And there was a lot more they did. They actually went and called for support to get money to buy oxygen tanks. And I actually said to Dr. Tom Boyle that no, they must not feel so desperate that they don't have support. Let's go and work in. I went in there, looked at the place, and I found that everything had actually been aligned. So I actually applauded their initiative of going forward to really mobilize support for the hospital. But as it turned out, we never actually ultimately filled the hospital because the numbers that did come did not match the capacity that we had. The question about Cuban doctors, we've got Cuban doctors here who have been assisting us, and I think it's important for us to always be fair about this, that we needed assistance, we needed reinforcement. We then invited the Cuban doctors to come in, and they can't work free of charge. They have to work on the basis of some reward like any other doctors, and they did a good job. As you will see, we gave out a report about some of the things they did. But of course, anyone who comes to work in South Africa knows that they're not coming to a country that's got no technical expertise. So everyone who comes in here knows that they're coming to learn as much as they might teach us something, but there is enough expertise in the country. And so we must always separate that the Cuban doctors, we've got, almost 3,500 or so who have gone through the Cuban training. It's a very well accredited training program, so there's nothing wrong with the Cuban. But sometimes, because we've got political views about Cuba, sometimes that overlaps in this whole issue. I wouldn't like to be dragged onto that one, but just to say that the Cuban doctors would be paid, the South African doctors would be employed and they would be paid. So everyone who assisted us, who was part of this whole thing, would be paid. And that's why I said, let's go and check how many were ultimately employed on the 500 that was offered by the South African Medical Association. But let me also say, I was an MEC many years back when there was a resistance in the medical schools from taking and increasing the numbers of doctors from disadvantaged communities, particularly blacks. That's why we ended up having to deal with Cuba. So it was not really just a thing that came about. There were actually deans that were serious fights about, and they were not prepared to support. And Cuba has actually come to support us and given us as much of training as we would have needed. And their training is not inferior, it's training that is good. In fact, in one instance, it's even helpful for us because when we talk about primary health care and national health insurance, we need a lot of focus on the community side of the primary health care. Very different from the kind of approach that we are using now, where we actually have people who look at communities and families and look at them and follow them up at home and so on and so on. So that's an ideal that at some point we might be able to get to. Then the other question, there are a lot of questions around NHI, testing site for NHI, CUPs and so on. I want to suggest, Dr. Kutsia, that one day we should actually open up a whole discussion around on NHI. We go through a presentation, prepare questions, we go through the discussion, because now there's a bit of space after COVID, so we should get back to that discussion. There are too many questions that are being raised on this matter that I think it requires us to have that discussion. The last two that I've picked up, assassination of doctors, I think that we've discussed that one in the context of the safety in hospital and in the context of the others, we have to actually work with the police. The last one relates to we must not copy other politicians in various countries. And so the lockdown is not good. I've seen that question. I think that we must know that we didn't follow any other only politicians on this matter. We just took a decision which we thought was best for South Africa. Many countries have now gone back to lockdowns when we've actually gotten out of the lockdowns. So every country is going to have to find ways of how to serve their situation. And in our case, we hope we don't have to go back to that. And hopefully we can all go out and promote the whole question of hand washing, masks and sanitizers so that we defer the return of the surge. At that level, let me say thank you very much, Dr. Kutsia.
Thank you. Before I ask the last topic, I just would like to say, I remember last year, Minister, you actually started a safety and security forum with one of the DDGs at National Department of Health. It went quite well, but I think since this year, I haven't heard anything again from that. And that was this safety and security forum was established as a regarding what happened before with the doctors that was shot in, I think it was in Limpopo, if I'm not mistaken. So that there is a forum, if one can just revive that forum again, I think that would add a lot of value. Then also, Minister, something that I think is important is around, that was also one of the questions that was posed, is the mental health issues and the healthcare workers, especially again regarding in this COVID time, as I know personally that a lot of this, especially specialists, are burnt out, and it's quite difficult to motivate them. And I'm not sure, but I know there's a lot of programs going on, but maybe, one needs to start to think about sort of a compulsory debriefing if you worked for for a month in ICU, for argument's sake. Or I think we need to look at something like that because of the trauma. It's immense trauma. Whether you are a doctor or a nurse, the trauma is quite high on that. And yes, SAMA will support an NHI webinar going forward. I think it's extremely important to look at that. And so I want to come back to one of the last questions, and that is the SAMA's request. But it's not only SAMA, it's SARA's, SAMA and SAMA's request of a possible independent medical and dental council. So I'm not sure whether you would recall that already in December 2019, SAMA and SARA is the South African Dental Association, we urgently call for a stakeholders meeting, and which was held to discuss some of the findings to the ministerial task team and the Mayosi report in 2015. And we, in that letter, both of us were vehemently opposed to the merger and aware of the view that the suggestions was flawed. That was where the HPCSA at that stage suggested that to merge the dental assisting, dental therapy and oral hygiene board with the medical dental and medical science board. So a bit of a background for people who doesn't understand that where we're coming from is the position of both SAMA and SARA is rooted in the 5th recommendation of the report of the medical task team, which was then chaired by Prof. Bongani Mayosi, which investigated allegations of administrative irregularities, mismanagement and poor governance of the HPCSA. And it also, this report highlighted the failure and dysfunction of the body, which in turn has resulted in the organization failing to deliver effectively and efficiently on its primary objectives and fundings in terms of the Act. Since then, you know, we haven't really seen any improvement in the overall function of the HPCSA. And I would just want to know from SAMA's side, what, you know, what is Minister's the view on this and going forward, because it's also important to understand that, you know, Minister, one of the questions also came up that how would you how will you ensure that effectiveness and accountability of these regulatory bodies, especially those where the entire board are appointed directly by a minister, as in the HPCSA, Council of Medical Schemes, Office of Health Standards, College of Medicines. You know, how can we assure that there's enough accountability and that they are effective? And that's the one part of the question. The second part of this question will then be, except now for what your views are on the independent council. So the second, if this industry have complaints regarding the functioning of these boards and organizations that's been appointed, you know, on a political level, where can we raise our concerns and how can that be addressed? I know it's a mouthful, but if you can just maybe give us a bit of an opinion here. Thank you, Minister.
Well, thank you very much for the question. That's the one question that I'm not able to give you one clear, straightforward answer. That is mainly because there are too many stakeholders here, and there's quite a lot of independent bodies. There's a lot of consultation that is needed to be able to refine ultimately to get something that works and as we solve some of the challenges. I would still suggest that on this one, because we have not concluded on the finalizing on some of the, firstly, the recommendation of the Mayosi Commission, as well as some of the issues that are being raised by the HPCSA as part of what needs to be done to restructure the councils, that we penned this one over and have another process of discussion and consultation on it. Just to say that the appointment of any boards by minister should not in any way make it impossible for any members of the profession to raise concerns, because at the end of the day, you can actually raise complaints and request investigation, and the matters will be given attention, even though those people would have been appointed by the minister. It's not to say that if the minister has appointed them, you can't have a way of raising objections. Any of those are supposed to be working in the interest of the entire society and the whole profession and society as a whole. And therefore, even a single individual can raise an objection or a complaint, and that will be investigated irrespective as to who it is directed against. So from that point of view, I think that there should not be a sense of uneasiness about it. However, there are lots of incomplete issues in the implementation of the Mayosi Commission, in the issues of restructuring that you're referring to, concerns of SARA, and so on. All of those are not concluded yet. So these are issues where we need to continue engaging until we get to the finality thereof. A lot of them would probably by now have been concluded, but because of the COVID situation, we've just put a lot of those issues on the side. In a number of instances, we've had to extend some of the bodies a little bit because we needed to get enough time to apply our minds on those particular changes that are needed. So we'll have to get a bit more discussion on that, further engagement as well with SAMA, and then we'll get the matters concluded at some point, but they're not ready yet. Then you raise the issue around trauma, mental health and trauma. Oh, that's a real issue. It's a big, big issue. I've noticed somebody had raised it here, the post-traumatic distress disorder on a number of people. It's a reality that we've had to face, and we have only to be conscious of the fact that this calls for additional resources on the mental health side, but it obviously is one of those where we need to open up and look at beyond just the mental health sections of our department, but also look at the multi-stakeholder roles in helping us to do socio-cultural counseling that's associated with the trauma that we've gone through. COVID-19 has just exposed all of that. Not only was the issue of the fear of one person or one professional that they could get infected, but the fear of infecting your own family has been a huge issue. The fear of getting infected as a result of shortages of PPEs, poor understanding of the risks in the various areas, it's really been a big problem. So again, here where we've got suggestions, we need to look at what suggestions there are. But from the point of view of the Department of Health, we are aware that there's a huge need for us to focus on the mental health, not only because of this COVID. But you see, if you go into the community and look at the gender-based violence and the crime that is all there, all of these are actually conniving to worsen the challenges of our mental health. And it's still partly even a carryover of our violence-torn society over many years. So it is actually a big challenge that we have to find ways of how to resolve. But it's a long haul that we have to understand. Mental health is one of the biggest of our causes of morbidity that we have to carry with us as we move on. So again, on this one, we agree with you, and we just will continue to take suggestions from what your experience has shown. Thank you very much.
Thank you, Minister. Before we are asking Dr. Mzukwa to end this meeting, I just would like to have just a brief summary. I agree that we need to have an NHI webinar where we again highlighted some of the problems and some of the positiveness, the positive things that can come from that, and some of the negatives, so that we are all on the same page. I also understand, that the act is not in place yet, so this is just thinking and role playing about how one can go ahead, because universal health coverage is extremely important in South Africa. Then I think we need to sit with National Department of Health and look at a policy type of thing around mental health and people, trying to identify what type of people just need to have a debriefing session, or what can we do in some, in people experiencing high PTSD, especially in relationship to their work. Then on the telemedicines, we have under the Unity Forum already decided that we will have to have a roundtable discussion. And one of the things that is extremely important is that we need to take cognizance of the lessons that we have learned this last 6 months in the COVID and the way that especially the big corporates jumped onto this bandwagon. It should be practitioner-led and driven, and we should actually be the ones saying how we see and where's the value of telemedicine, and not the big corporates out there. That's one of the lessons that we have learned. Then also understand that that you will engage with some of the organized associations regarding the decriminalization or the criminalization, how we can work together, not specifically on this specific case that we are all aware of, but going into future. We also understand regarding that you cannot give a final verdict on the independent counsel, but you are aware of SAMA's viewpoint there. And then also we will liaise with Khadija, and we will also liaise with Nicholas Crisp again. And we would also then please ask that we are more involved in matters directly affecting the profession. I know we're not all academics and we're not all profs, but I can promise you we've got a lot of experience in the coalface, and we would love to give our input. And it's fine to differ, and it's fine to not always sing the same song. Actually, that learns as other songs if we have more than one song to sing at the end of the day. And then again, thank you so much to everyone here tonight. And with this few words, Minister, I'm going to hand over to Dr. Mawisi Mzukwa, my vice chair and my trusted friend. And thank you so much again for your willingness. I know it's a long day and it's a long night. Thank you so much. Bye-bye.
Thank you. Thank you so much, Dr. Angelique Kutsia, for such wonderful words. Let me first thank Honorable Minister of Health, Dr. Zweli Mkhize, for his time, his insightful presentation, and the manner in which he interacted with us as the profession. We're truly proud to have you in the leadership of the Department of Health. And we are also would like to assure you that we are behind you in the quest to further the health of all South Africans. Secondly, to your team as well, we would like to acknowledge the administrative team there, led by the DG and all the colleagues up there. We thank you so much for your time. Secondly, to Mr. Fourie. Hey, Mr. Fourie, that was very inspirational. It was a very powerful talk, and we really thank you for that. And I think, we really, you gave us so much hope from that presentation. It was really empowering to all of us. To our PPS who sponsor us all the time, including this event, you are always a good partner to us. We appreciate that. Our DM and the fellow board members of SAMA who attended tonight, we really thank you for your presence. To Dr. Vusi Nhlapo, our general manager, thank you for your guidance and for making this event possible. And the administrative side, to the team who worked behind the scenes to make this event possible, we really extend our appreciation. And also to our colleagues who took their time and attended this presentation and this engagement. We truly appreciate that, and we hope to see you in the next engagement, as there is a possibility for that, as alluded to by our chair and the minister. We really appreciate that, and we wish you all the best. Take it from us that we, we truly appreciate this. With those words, I would like to say good night and very good night and a very good sleep. Thank you so much for that.
Thank you, Dr. Mzila.
Thank you very much. Thank
Thanks a
you.
lot.
Good night.
Good night.
Cheers. Thank you.
Thanks.